Hello, everybody, and welcome back to MBME 27. We finished the first 100 questions. Go check out those videos. And now we're going to start on 101. The first question is, a 25-year-old man comes to the clinic for evaluation of recurrent bruising and gum bleeding. Started 4 weeks ago after recovering from mild illness. He denies any family history, bleeding disorders. Scatterpeteche is seen, and small ecchymosis on his lower legs. Hemoglobin 13, white blood cells 6,200, platelets 12,000, and then normal PT and APTT, which describes the underlying mechanism. So the bone marrow compensates by increasing the megakaryocytes, which is exactly what you'd see if they give you a big old image. It'd be these big multi-lobulated cells. The bleeding symptoms and isolated thrombocytopenia and the normal PT-PTT time suggests ITP. It's important to acknowledge that we have compensatory bone marrow findings. Here, antiplatelet antibodies opsonize the platelets, and then the macrophages in the spleen will phagocytose them. That ends up in decreasing the amount of platelets, and then you have increased bleeding. And so the bleeding comes from the lack of platelets. But A is trying to get us to think of impaired platelet adhesion due to lack of von Willebrand factor. That's menorrhagia would be seen in prolonged PTT. That's von Willebrand's disease. But here we have a normal PTT, so that can be the right answer. B says consumptive coagulopathy of fibrin deposition. Consumptive coagulopathies are referring to DIC, disseminated. And there you'd look for elevated PT, PTT, decreased fibrinogen, and also you'd have an increased D-dimer. And that's not seen in this question, so it's not the right answer. C is correct. You have the antibodies that opsonize the platelets, and the macrophages in the spleen eat them up. Chomp chomp. D says platelet aggregation from the ADAM at TS13 deficiency. That would be seen with neurological symptoms, renal failure, schistocytes. You should think TTP for that one. TTP. Because ADAM TS has that T in it, it's going to have an extra T as well, TTP. E says cytotoxic T-cell mediated marrow suppression. An example of that would be aplastic anemia or viral marrow suppression, so you'd see pancytopenia, not just isolated thrombocytopenia. And thrombocytopenia, by the way, is just a deficiency in the platelets in the blood. It causes bleeding in the tissues, bruising, and slow blood clotting after the injury. So just to really clear this up, ITP is an autoimmune condition where your own antibodies tag your platelets for destruction. Think of it like this: immune tags platelets, ITP. The spleen sees those tagged platelets as invaders and it clears them out. And so that's why the patients have low platelets but normal coagulation tests. Megakaryocytes are just large bone marrow cells that are responsible for producing the platelets. They're going to be big, multi-lobed kind of guys. You can also see bruising, petechia. That's the small purple spots that are caused by bleeding on the skin. And also blood and urine in the stool. And so in this question, there's a patient with mucocutaneous bleeding, very low platelets, and normal PT and PTT, and reactive marrow, so that's ITP. They're always going to give you distractors like TTP and like DIC, but those guys are going to have schistocytes or abnormal labs, and that's why they're not the right answer. So like your body makes platelets just fine, but then the immune system destroys them in the spleen. That causes bleeding even though the bone marrow is working really hard. So watch out for bleeding gums, nosebleeds, easy bruising, all that stuff, but also high megakaryocytes in the bone marrow because it's trying to compensate. And you will see antiplatelet antibodies. They might ask about that in another question. This is commonly after a viral illness of some sort or autoimmune diseases like adults might have lupus. Also HIV and hepatitis C can cause this as well, can trigger it. Okay, that was 101. Now we're going to go on to 102. There's a thing called the number needed to treat is just 1 over the absolute risk reduction. And the absolute risk reduction is the control event rate minus the experimental. So in this practice question, we have the effects of dietary supplements and adverse pregnancy outcomes. A cohort of 5,000 women, 2.5% of those given standard prenatal vitamins had newborns with congenital abnormalities. But only 1% of those who had enhanced formula had those outcomes. How many women would need to receive the formula to prevent one congenital anomaly? So it was 2.5%, but then it went down to 1%, and that's a difference of 1.5%, which is 0.015. That is the absolute risk reduction that we have just found here. And we said that it's the reciprocal gives us NNT, the number needed to treat. So it's going to be 1 over 0.015 will be the number of people that we need to treat here, and that's 0.6 repeating, so 0.67. And now we know that the number needed to treat is about 67. So 67 would actually be our answer here. And if we wanted to see out of the 5,000, how many of the 5,000 would be helped, you just divide that by 67, and that would be about 74 of those women would have been helped. So the benefit of 5,000 women would be about 74, 75 cases of congenital anomalies that are. But the only things to think about here is you find the absolute rate reduction here. So it was 2.5, now it's 1. And then the number needed to treat is just 1 divided by that decimal. Okay, now we're going to do like a fun real example with COVID because I think this is going to illustrate the point. Now, this is actually real data. So the median number needed to vaccinate to prevent one COVID vaccination was 205 people, and one ED visit was 156. So here's the calculations. A public health department plans to administer a booster to 41,000 individuals. How many hospitalizations can be prevented? All right, so we use that NNV of 205, and then we have 41,000. And 205 would be about 200. So 200 hospitalizations would have been averted. So for every 205 people that are boosted, one COVID hospitalization is prevented. You could also run the math and it says every 156 people that are boosted, one emergency department visit is prevented. All right, there's 102. Let's go to 103 now. All right, a 30-year-old man has a history of generalized tonic-clonic seizures, is being prescribed a new anti-epileptic. He's got improved mood stability. Genetic testing reveals increased expression of BDNF, mRNA, and cortical neurons. The drug increases histone acetylation by blocking histone deacetylase. Which of the following is the primary cellular effect of this medication? Well, they said that it had a mood stabilizing effect. And valproate is a mood stabilizer that's often used in bipolar disorder. And how this works is it increases the transcription through that exact mechanism in the question. And we're talking about acetylating, histones, deacetylating. All that stuff has to do with transcription. And in fact, the answer is going to be C, stimulating the transcription. Because histone acetylation, you have your chromatin in your DNA. Acetylation relaxes that chromatin structure. And that allows the transcription to bind more effectively. So valproate and other HDAC inhibitors enhance gene expression. They do this by inhibiting histone deacetylase. Deacetylation is when you tighten it. And valproic acid blocks histone deacetylase. So that means the acetyl groups stay on and DNA is more open, and more genes get transcribed. And specifically, if you're interested in the mechanism, it increases the helpful brain genes like BDNF, the brain-derived neurotrophic factor, which then supports brain plasticity and mood stability. So the answer has to do with transcription. It's not mRNA splicing that happens after transcription. It's not polyadenylation that would help protect the mRNA, not control the gene access. Valproate is just working a little bit earlier than a lot of these answer choices. And translation is not even affected by your histones at all. All right, that was 103. Let's move on to 104. A 22-year-old student presents with a history of frequent nosebleeds, heavy menstrual cycles, and easy bruising. She underwent wisdom tooth extraction and reports that bleeding lasted over 10 hours despite local pressure and gauze packing. She denies any family history of hemophilia. Lab shows hemoglobin 12, platelets 275,000, normal PT, upper normal of PTT, prolonged bleeding time, decreased risk of seed and cofactor 8 is mildly decreased as well. Didn't have to give you all of this. This is clearly defective on Wilbrand factor. Now, the problem with our 22-year-old college student is she has enough platelets. Like that platelet count is just fine. They're just not sticking properly. So they're no stick, but they're all the way up there in a good range. They just don't work. There's an increased bleeding time, and that's classic for von Willebrand's disease because the platelets can't stick together, or rather they can't stick to the injured blood vessels. There's also low factor 8. That was really nice of them to say. Von Willebrand factor protects it. So without that, factor 8 will break down. The low ristocetin code, well, von Willebrand's is not working because the ristocetin test is abnormal. So you might ask, what is ristocetin? That's a test that checks whether von Willebrand factor is doing its job. If the test is abnormal, then von Willebrand factor is not working. If it were hemophilia, you'd see joint and muscle bleeds, normal bleeding time in male patients would be X-linked for hemophilia A, that is. For hemophilia B, that's factor 9 is the same as hemophilia A, but it's not mucosal bleeding. The bleeding time would be normal. Vitamin K would increase the PTINR, not the bleeding time. It affects the factors 2, 7, 9, 10, not von Willebrand factor. So they're just not sticking very well. So you get the nosebleeds, gum bleeding, heavy periods. The bleeding time increases, or just von Willebrand factor concentrate if the bleeding is super severe. Okay, here's the explanation. Factor 9 deficiency would be hemophilia B, deep bleeds, autoimmune platelet destruction, ITP, we had a question on that. You'd have normal ristocetin test if it were Glanzmann's though. Vitamin K deficiency would have an elevated PT because of that factor 2, 7, 9, 10. So you see this when your platelets are normal and the ristocetin test is abnormal, but you have normal PTT and bleeding time for ITP, whereas these guys right here are going to be longer. There's no sticking with the platelets. All right, so that's 104. Let's go on to 105. Here we have a 28-year-old woman who presents to the clinic with a 4-day history of fever, body aches, painful genital sores. She reports having unprotected intercourse with a new partner 10 days ago. On exam, there's several small, shallow ulcers with erythematous base. Okay, so probably some form of herpes. Herpes 2, probably. Otherwise healthy, a swab of one of the lesions is sent for PCR testing, which best explains the pathogenesis. All right. She's got painful sores, vesicles, genital herpes, HSV is what she's probably got. The hallmark features are painful sores that burn, itch, and tingle before the vesicles erupt. HSV, I like to think of vesicles. And these are group vesicles on an arithmetic base that rupture into shallow ulcers. So you get that progression from the vesicles to the ulcers. There's also the tender lymph nodes in the groin. So you have inguinal lymphadenopathy. Systemically, you could have the fever, headache, myalgia, and also you can have reactivation because this is going to hide in the sacral ganglia. So stress, illness, or compromised events can trigger the reactivation. And the microbiology is interesting because it's a virus, right? Herpes simplex virus is usually HSV2 for genitals, and HSV1 can also cause it. It's double-stranded. It's the sacral dorsal root ganglia. There's a latency site. So it's going to hang around that S2 to S4, just sacral, just chilling there. And the contact is sexually transmitted or vertical through the birth canal, and skin-to-skin contact is how it's transmitted. Treatment is cyclovir, famiciclovir, they're guanosine analogs. They inhibit viral DNA polymerase, and they're used for outbreaks or even daily suppression. Let's talk about why these answers are wrong. Cytoplasmic RNA replication. So that's RNA, but this is a DNA virus. That's why it's wrong. Bacterial invasion of disrupted mucosal surfaces. Well, that's chancroid or syphilis, but they don't cause vesicles or that prodrome. So the chancroids like Haemophilus ducreyi, that's really painful. And you'd also have the itchy exudate. You do cry with these chancroid. Integration of viral DNA. So that could be like HIV or HPV. This does not integrate into host DNA. HPV would, though. So that would cause genital wart, condyloma acuminata, the flesh-colored cauliflower growth. It's super, super disgusting. Oh, I just got chills. Woo. Her lesions are painful, and that chancre is painless. Chlamydia would start as a small painless ulcer, and then it'd be painful and swollen lymph nodes. You have the buboes for those, chlamydia. And yeah, that's syphilis. Be a painless chancre, be primary syphilis, and then painless papules. Condyloma lata in the secondary. So just like to kind of zoom out and make sure we get this content down. The painful stuff could be the HSV vesicles or the chancroid. And then the painless stuff is like syphilis that has a clean base. LGV would be a tiny little ulcer. And HPV would be warts. So know that HSV is an enveloped double-stranded DNA. HSV stays latent in the sacral ganglia. The drug target is viral DNA polymerase. They might ask you which herpes is oral, and that would be HSV1, but it can cause genital as well. And also HSV2 can cause septic meningitis, especially in women. And so a way to remember this is you say herpes hurts. You remember the V stands for vesicles, and you can also remember herpes hides in the ganglia. All right, so that was 105. Now let's go on to 106. A 2-year-old boy is evaluated for developmental delay, hypotonia, and brittle hair with a kinky appearance. He has snagging facial skin, multiple joint dislocations, copper levels are low. A deficiency in the enzyme responsible for extracellular post-translational modification of collagen is suspected. Well, that means it's lysine. This is where we have impaired copper transport. Occurs because of that lysyl oxidase deficiency. So if you don't have lysyl oxidase, then the lysine residues can't be deaminated into aldehydes, and that prevents their essential cross-linking that gives the collagen its strength. So all of this 2-year-old symptoms are caused by that lack of collagen strength. And so think about it, the brittle hair, the connective tissue, the hypotonia. He's got the facial skin that sags, joint dislocations, low copper. All that points toward lysine. So just zooming out and making sure we nail this down, collagen is used for many things. It's used for the skin, the bones, the tendons, the blood vessels. It's a main structural protein in your body. And collagen synthesis has a couple of steps. So step 1 is first the mRNA makes the pre-procollagen in the ribosomes. Hydroxylation of the proline and the lysine must happen for the creation of collagen. And then we undergo glycosylation, and that's where you form the triple helix, and that's procollagen. Once you've glycosylated, you get the procollagen. Then you can undergo exocytosis, where the procollagen is secreted outside of the cell, and then it's cleaved. The procollagen goes into tropocollagen by cleaving the ends, and the procollagen peptidase is going to help out with that step. And then at the very end, 1, 2, 3, 4, 5, 6, we do cross-linking. And that's what's wrong in this kiddo. It's copper dependent. So lysyl oxidase converts lysine to aldehydes and it forms the cross-linking. But that step can't happen if you don't have the copper. So we need vitamin C, or else you get the scurvy for that step. And then also for that cross-linking, we need copper. So that's why our answer here is lysine. Glycine, every third residue in the collagen triple helix, it's needed for helix formation, not cross-linking. So it's not glycine, but it's not involved in collagen synthesis. And proline stabilizes, but it's not reactive for cross-linking. So lysine is what contributes to the strength of the tendons, the skin, and the bones. And the enzyme is lysyl oxidase, responsible for converting the lysine to reactive aldehyde that lets the collagen molecules lock together to form the sturdy fibrils. But this is when it's already outside of the cell, it's already done its thing. you need some copper as well. So lysine does the cross-linking. All right, now let's do 107. So here a 68-year-old man presents with a routine dermatology checkup. He spent much of his adult life working as a farmer in the Midwest. On exam, he's got several scaly pink plaques with gritty texture in the dorsum of his hands and temples. Lesions are non-tender, non-bleeding. He denies itching and pain. Yeah. What's the most appropriate management? Cryotherapy with liquid nitrogen. He's got actinic keratosis. There are a couple things that warn us. He's a 75-year-old man, so he's getting up there in age. He's got some painless, rough skin lesions, and he's worked outside for 30 years. That's the huge giveaway. The lesions are gritty and rough to the touch, so this is actinic keratosis. It's pre-malignant, caused by chronic sun exposure. So that texture is rough, sandpaper-like, and the color is pink, or it can also be red sometimes with the yellowish crust. The location is the sun-exposed areas, so the face, the ears, the scalp, and the hands in this case. It can slowly turn into squamous cell carcinoma, about 1% likelihood each year. The pathophys, how it happens, is you've got the sun is deadly laser. We already knew that though. It comes in, it damages DNA in the skin cells, usually the keratinocytes, and mutations accumulate, especially in the TP53 tumor suppressor gene. So the TP53 goes haywire, and then the skin becomes dysplastic. You get atypical cells in the basal epidermis, and the damage will spread deeper. So partial would be actinic keratosis. Full thickness through the whole entire epidermis is going to be known as squamous cell carcinoma in situ. So that's the Bowen's disease. And then if it invades in the dermis, then you already have invasive squamous cell carcinoma. So full thickness of the epidermis is Bowen's, and then invades the dermis is invasive squamous cell. And so cryotherapy just freezes it for a single lesion. You also have topical 5-fluorouracil or photodynamic therapy for many different lesions. Now, they can try to confuse you with a whole bunch of other stuff. Let's see why they're wrong. Observe and reassure. This is good for benign stuff, but this is pre-malignant. You don't want to reassure somebody about a pre-malignancy. Oral isotretinoin, that's for severe acne, so that's crazy. Surgical excision with 5mm margins, that's invasive skin cancers, not pre-malignant stuff. Systemic chemotherapy is way too aggressive. No. This is pre-malignant. And then solar lentigo. That's the flat brown spots, like the liver spots. They're not rough, and there's no cancer risk there. So actinic keratosis can turn into squamous cell. It'll slowly progress if it's untreated. So definitely use sunscreen, guys. It's good for you anyways. Everybody has to use it. Even if you're indoors, you can still get some damage even if you're indoors. All right, moving on. Now we're on 108. We have an 81-year-old woman with type 2 diabetes, hypertension, and dementia brought to the emergency department with confusion and mild shortness of breath. Her son says that she's been more agitated and refused to eat today. Her vitals are 100 degrees, heart rate at 118. O2 is 90% room air. On exam, she's disoriented. EG shows ST elevations in leads 2, 3, and AVF. Troponin is also elevated. So the correct answer is she has a rupture of a vulnerable atherosclerotic plaque. The way that I think about this presentation here is we got chest pain, ST elevation, and crackles. Tells us it's a myocardial infarction. It's a type of acute coronary syndrome. So acute coronary syndrome, what even is that? That's a blockage of the blood in the heart muscles, especially due to a ruptured atherosclerotic plaque. So there's like a clot there. And there are 3 types that we need to know for this exam. There's type 1 would be like an unstable. There's unstable angina. That has no biomarkers and no ST changes. And then there's an NSTEMI, and that's where we do have troponin and also ST depression and T-wave inversions. And there's a STEMI. So these are the 3 types. So the STEMI does have the elevation, STE, right? And then the NSTEMI has ST depression and T-wave inversion. And the pathophys here is you have an atherosclerotic plaque that ruptures in the coronary artery. And then you have platelets and clots that start to form, and that will block the blood flow. And the myocardium then becomes ischemic, so you get an infarction. Then you have dead tissue that triggers inflammation and pain and dysfunction. And if it's severe, then you have heart failure. You can also get pulmonary edema and arrhythmias. So ST segment elevation means that we got a full thickness thing going on. We also have the crackles. That means there's pulmonary edema. So that means there's left heart failure. Because if you think about the heart like this, it's got to go to the lungs first, and then it comes down to that left side. So it's going to be heart failure over here if you have pulmonary edema. It's leaking out. It's getting backed up in the lungs. That's why you have the edema. Systolic murmurs at the apex could be mitral regurgitation from the papillary muscle. And the treatments, you give them aspirin and clopidogrel. The antiplatelets will stop the clotting. So give her the aspirin and clopidogrel. Also heparin, that's an anticoagulant that'll prevent further thrombosis. Also nitroglycerin, that's vasodilation for symptom reliefs. It'll just make them feel better if you give them nitroglycerin. And then beta blockers would decrease the O2 demand unless they have signs of shock. And then reperfusion, a stent would probably be preferred here, or thrombolysis. Now, there are a lot of things that it's not, and let's see the reasons why. Fibrinous pericardial inflammation. Pericarditis has diffuse ST elevations that's not localized to one lead. Pulmonary embolism and deep vein thrombosis. You'd see tachypnea and hypoxia, but ST elevations would not be typical there. That'd be pulmonary stuff. We couldn't breathe. Cytokine-mediated inflammatory response would be sepsis. You'd see fever and infection, not ST elevations necessarily. Cerebral microvascular ischemia stem from stroke, but no neurodeficits. So the way to think of these guys, you could think of like ACS, acute coronary syndrome. And you could think the A stands for your angina, which is unstable. C stands for a clot, your end STEMI, and then ST elevation, of course, is STE, ST elevation. And also, you should know when you're looking at the LAD, anterior lateral would be V3 to V6, also 1 in AVL. And then the lateral leads, the lateral wall is 1, AVL, V5, V6. That'd be lateral, so left circumflex typically. Inferior wall, like the RCA, is 2, 3, and AVF. Posterior wall, you'd see ST depression in V1 to V3. And so here we just focus on the LAD. That's the anterior wall, so the anterior 2/3 of the interventricular septum. It's the deadliest type of myocardial infarction if you have an occlusion there. All right, next we're going to talk about 109 here, and let's talk about hydrochlorothiazide. It lowers the blood pressure by blocking sodium chloride urine Cl reabsorption in the distal convoluted tubule. Also, you get that calcium increase reabsorption. Carbonic anhydrase inhibitors are on the proximal side, like the sodium hydronium exchanger, and decreased bicarbonate reabsorption. And the potassium sparing ones act in the collecting duct and the ENaC channels. And then mannitol is on the proximal tubule. So hydrochlorothiazide's first line for mild diuresis and vasodilation, because you can have decreased calcium excretion, but also osteoporosis. Increased calcium retention can also help the bone. And in mild heart failure, you can use this to control the fluids. And so the things you have to know is that it increases the serum calcium because less is excreted. It can cause hypokalemia and metabolic alkalosis. It works best with normal kidney function when the GFR is greater than 30. And the side effect would be hypergluc. You have the glucose, lipids, uric acid, and calcium. Uric acid, glucose, lipids, hypergluc. That's 109. All right, next is 110. I'm going to take a break. So here we have a 32-year-old woman with obesity, irregular menstrual cycles, and facial hair, lab show elevated testosterone, and LH and low FSH. Endometrial biopsy reveals simple hyperplasia without atypia. Which substance is synthesized in excess? Estrone is the answer. This is polycystic ovarian syndrome. They've got anovulation, hirsutism, obesity, cystic ovaries, and endometrial hyperplasia. Hyperandrogenism, elevated testosterone, is converted into S via aromatase. I'll let you guys read that, but essentially we have a 30-something obese woman. She's got anovulation, enlarged ovaries. She's got some cysts on them, some hirsutism, and she's found to have endometrial hyperplasia. This is going to be PCOS, and that's because of all that fat to adipose tissue causes the estrogen. It's the pathophys is that first you have the insulin stimulates the LH. You have that increased LH-FSH ratio, and that stimulates the theca cells to produce more testosterone. You have decreased FSH, leads to impaired follicle maturation, and all that excess androgen causes the hirsutism and the hair growth. And aromatase of the adipose tissue converts to testosterone into estrone, so estrogen, and that unopposed estrogen causes a risk of endometrial hyperplasia and cancer. So adipose tissue via aromatase, weak estrogen stimulates endometrial growth. More fat means more aromatase, more estrone, which means higher estrogen exposure. So PCOS impact has a cycle irregularity, anovulation, endometrial hyperplasia. So aromatase converts androgens to estrogen. And so then estrone is the main estrogen that's made in postmenopausal women and obese individuals. In PCOS, the high estrogens and high estrone are present. And so the risk is endometrial hyperplasia or cancer because of all that unopposed action. And so the way you treat this is with weight loss or OCPs with progesterone. And that'll protect you, protects the endometrium. Remember, progesterone protects. And also clomiphene can help induce ovulation if they're struggling with that. Now, some other answers that aren't correct would be aldosterone. That's made in the zona glomerulosa. It's not going to be related to your adipose tissues. Cortisol could be another answer that people might throw at you. It's made in the zona fasciculata, not the adipose tissue itself. 20-alpha would be rare, weak, metabolic, and not from adipose. So really it's just focusing on what is fat derived. And the answer is also not progesterone because that's from the corpus luteum, not adipose, and it's used to oppose estrogen, so that wouldn't even make any sense, even if you tried. But some questions that might arise is why is FSH going to be decreased in PCOS? And so the normal physiology kind of goes like this. Normal physiology has GnRH from the hypothalamus pulses at different rates. The slow pulses contribute to FSH and the fast pulses to LH. So in PCOS, you have a high frequency of GnRH pulses, and that favors the LH over the FSH, and that leads to an increase of LH over FSH. And that ratio is often something like 2 to 1. So FSH is needed to mature the ovarian follicles, and so if you have low FSH, the follicles don't mature, and so you get anovulation and cysts. So how does insulin resistance cause a hormone change, though? Well, insulin In PCOS, many patients have insulin resistance, and that leads to hyperinsulinemia, so high insulin in your blood. And what high insulin does is it stimulates the theca cells. There's more androgen because of that stimulated theca cells, like, think testosterone. And that inhibits your SHBG production by the liver. So you have more testosterone in circulation, is all that means. And that'll worsen your LH dominance and makes GnRH pulse frequency even faster. And it also could alter your GnRH secretion, right? It'll lower your FSH over time. So more androgens, less follicular maturation, and all that good stuff. So really, this is a disease about insulin resistance if you think about it, because insulin directly stimulates the theca cells, gives you more androgens. And that's the main cause of the hirsutism, is that you're producing more androgens like testosterone. And insulin also lowers that hormone-binding globulin, binds up the free testosterone, but you have decreased here, so free testosterone is more active. And so that's the role that insulin plays here. Increased androgen through the stimulation of the theca cells, increased free testosterone from the decrease of the hormone binding, and also increased LH because of that GnRH pulsatile action, and then endometrial risk because of the growth factor. So insulin essentially turns that PCOS from just a normal hormonal imbalance into a full body syndrome. There we go, folks. We've done these 10 questions here. We'll be moving on until we've completed this. Please be sure to like, comment, and subscribe. I'm always trying to improve. Also, you can see that the lights behind me are going to change, and they change depending on who subscribes. So please send a subscription my way, and it'll change the light. Also, just helps me spend more time making better and better videos for you guys. So it's no cost to you guys, but it definitely helps out the channel. See you guys in the next video.